known as congenital aortic stenosis. If anybody has a doubt, you can put in a question or ask questions directly. It is best to be interactive. So what is the definition of aortic stenosis? Aortic stenosis is a narrowing of the aortic valve. So what happens? The left ventricle has to pump blood against a resistance into the ascending aorta. So this abnormality is produced. What happens is the aortic valve does not open well, so as to allow the free movement of blood from the left ventricle to the aorta. So compensation happens in the form of concentric LV hypertrophy because of increased left ventricular pressure. So this is the normal aortic valve on echocardiogram. You can see on my slide, you can see there are three cusps. So we call them the anterior cusp, right and left cusp, and the non-coronary cusp. Actually, this picture is slightly rotated. See, the left cusp, usually the right coronary cusp is more superiorly located, and then we have the left and right cusps. The left coronary artery comes from the left coronary cusp, and the right coronary artery comes from the right coronary cusp. And you can see this is how the valve actually opens. And you can see that the leaflets are attached at a point which is known as the commissure. So it is when the commissural fusion happens that aortic stenosis happens. So valvular commissural fusion is a characteristic feature of aortic valve disease. This is again the anatomical pictures of the cusps, the leaflets, and how the leaflets look like when the aortic valve is open. You can see it's a wide opening. If you look carefully, this is also the Benz sign. You can see the tri limb sign of the Benz, and when this is present, almost invariably the aortic valve is normal. So this is the normal aortic valve. So what are the causes of aortic stenosis? Important causes is bicuspid aortic valve. Sometimes aortic valve can congenital other anomalies like unicuspid valve, and there are other causes of congenital aortic stenosis like subaortic membrane, or supravalvular aortic stenosis, or a tubular thickened ascending aorta, all of which impedes flow into the ascending aorta, can produce LVOT obstruction. So the commonest cause is abnormal aortic valve. It can also be produced by rheumatic fever. Aortic stenosis also can be produced in the elderly because of calcific changes and dystrophic changes which happen in the aortic valve. Today, we'll focus on bicuspid aortic valve and congenital aortic stenosis. So this is the normal aortic valve. You can see this is the congenital aortic valve where there is commissural fusion, and you see the small opening of the aortic valve. The rheumatic aortic valve characteristically has thickening and eversion, eversion of the valve leaflets as well as commissural fusion. So let's see. So if you look at left ventricle, so this is the left ventricle, the left atrium. This is the aortic leaflets, and this is the ascending aorta. I'm just showing you the various structures involved in the left ventricular outflow tract. And any of the obstructions, any of the abnormalities in this outflow tract also can produce symptoms similar to the aortic valve disease. So bicuspid aortic valve is the commonest form of congenital heart disease. It's 1 to 2% of the CHDs, and it's very common. Bicuspid aortic valve is common in 1 to 2% of the population, and we know it is some form of inheritance pattern is also there. The bicuspid aortic valve is also associated with progressive dilatation of the aorta because there is some fibrillin abnormality in the aortic wall. It is also associated with sometimes left side other obstructive lesions like subaortic membrane or obstruction in the aorta like coarctation, and it's also associated with the what is called as the left dominant system. And we have also seen that the left coronary artery, predominantly the LMCA, happens to be little shorter in about 50% of cases. So bicuspid aortic valve can produce severe aortic stenosis. It can progress with age, It can also produce aortic regurgitation. So this is how a bicuspid aortic valve looks. You can see the fusion produces a transverse opening of the aortic valve. This is the echo picture of it. And now you have, instead of 3 leaflets, you have only 2 leaflets, and you have a superior and inferior leaflet, or a right and left leaflet. So that is how the different fusions produces different types of morphology of the leaflets. So this again a picture showing the normal tricuspid leaflet, normal tricuspid aortic valve opening. Here is the fusion between the right and the left coronary cusp, and this will be between the right and the non-coronary cusp. And you can see how the leaflet opening is changing, and the different types of leaflets orientation is also changing depending upon which commissures and which leaflets are actually fused. This is a 3D echo picture which shows fusion of the anterior commissure, and you can see the thickened raphe. So 3D pictures show good quality imaging of the aortic valve and tells you exactly what is the nature of the abnormality, and also we could also find out how exactly we can position our catheters during a planned procedure for aortic valve disease. This is an echo picture with the parasternal long axis view showing the thickened aortic valve. You can see the interventricular septum is thickened. You can also see the post-stenotic dilatation of the ascending aorta. So as I've said, most patients with congenital aortic stenosis have severe hypertrophy, and they can produce heart failure. It's also one important cause of adverse outcomes in around 1 to 2% of patients with significant aortic stenosis. The aortic stenosis can present in 2 ways. It can present as a duct-dependent systemic circulation in the newborn period. That is, when there is severe aortic stenosis, there will be when the baby is born, the first 2 days it will be okay, but when the PD starts to close, there is decreased systemic outflow. So critical aortic stenosis is one of the conditions in which the child develops severe shock, and there is absence of pulse in all 4 limbs, and these children are severely sick, and they need intervention in the first 24 to 48 hours. These babies can be stabilized with prostaglandin to open the duct, and then transported to a good center where the appropriate treatment like balloon aortic valve dilatation can be done. So any baby who develops shock or collapse can have duct-dependent systemic circulation. The characteristic feature are poor perfusion, absent pulses, pallor, and shock. The other important cause of aortic stenosis is rheumatic fever, which is currently less common in Kerala, but developed in other countries. It's almost invariably associated in combination with mitral valve abnormalities. So there's often associated mitral regurgitation or mitral stenosis. So what are the main symptoms of aortic stenosis? Most of the children with moderate to severe aortic stenosis are asymptomatic. The 3 main symptoms are dyspnea on exertion. That means when the child plays, child can dyspnea, can have chest pain, and can develop pre-syncope or syncope. It is important to know that severe aortic stenosis can be totally asymptomatic, and the onset of symptoms, the patient deteriorates quickly. So onset of symptoms heralds a dramatic increase in mortality if we don't do anything. So it's very important that aortic stenosis per se can be severe but can be asymptomatic for a long duration of time. This is because the left ventricle hypertrophies and is able to maintain cardiac output by increasing the pressure in the left ventricle. So this is the graph which shows the latent period where we can have a long period of time with no symptoms, and then suddenly when symptoms starts, the adverse outcomes begin to manifest, and the survival is as low as 2 to 3 years. So what are the findings? The important findings on clinical examination would be low volume pulse. The typical pulse in aortic stenosis is a slow volume, slow rising pulse. Pulse is parvus retardus is the name given to it. When you feel the pulse is of low volume. On taking blood pressure, you can see there's systolic decapitation. The systolic blood pressure is pretty low. So that's called systolic decapitation. You can also feel the thrill of systolic thrill, and also sometimes this thrill can be conducted to the carotids. So carotid thrill is also palpable. The apical impulse typically is forceful and heaving. Is well sustained because of the concentric hypertrophy. Auscultation will show you the first heart sound is normal. The second heart sound, when aortic stenosis is severe, will be closely split or it can be paradoxically split. In valvular aortic stenosis, you can hear an ejection click. This ejection click is closer to the first heart sound as the severity of aortic stenosis goes up. That's an important thing. So whenever you can hear an ejection click on auscultation, that tells you that the aortic stenosis is valvular in nature. So when there is a click, it tells you AS is valvular. There is also some relationship between the severity of aortic stenosis and the click. They say in pulmonary stenosis, they say as the click moves closer to the first heart sound, the aortic the pulmonary stenosis is severe. But that is not the case in aortic stenosis. The aortic click is constant and it does not move with the respiration nor with the cardiac cycle or nor with the severity. So that is why the aortic ejection click in AS or valvular AS is a constant ejection click. The other important finding is the murmur, which is an ejection systolic murmur. It's a crescendo decrescendo murmur. And as the intensity of the obstruction increases, the murmur peaks later. And the second heart sound becomes single. So ejection systolic murmur with late peaking is characteristic of severe aortic stenosis. Regarding heart sounds, I said you can have very closely split second heart sound or a paradoxically split second heart sound. The second heart sound typically in aortic stenosis is single because the aortic component is not heard. You can have third heart sound or a fourth heart sound when there is severe LVH and heart failure. S3 is characteristic of heart failure. I think these things I said, the pulsus parvus retardus is the characteristic way of assessing aortic stenosis at bedside. But there are important caveats to this. The two important caveats you should know are, one is in children, even though you have severe aortic stenosis, sometimes the pulse can be normal. That is because the left ventricle is so good. That means its contraction is very good. It is able to overcome the obstruction and the pulse volume still remains normal. Similarly, in elderly patients, in the adult, because of hypertension, also, even if you have severe aortic stenosis, sometimes the pulse can be very brisk. And pulse, the palpation may not give you the insight that the aortic stenosis is severe. So these are the two important situations where, despite having a good pulse, patient can have severe aortic stenosis. So what are the diagnostic things you can test which we are doing is ECG, chest X-ray, echo, and in some cases cardiac catheterization. So what does the ECG show? ECG will show evidence of left ventricular hypertrophy in the form of tall R waves in V5, V6 and 1AVL and ST depression because of LV strain. That can also have left atrial enlargement in the form of inverted P wave in V1. So LVH with strain is characteristic of severe aortic stenosis. Chest X-ray usually does not show much, but you can also see the post-stenotic aortic dilatation. In elderly, you can see also the calcific aortic valve. Echo is the diagnostic tool which will show all the characteristic anatomical abnormalities and the functional abnormalities that are characteristic of aortic stenosis. Cardiac catheterization sometimes is required. It's usually a part of the therapeutic procedure where we find the pressures and we cross the aortic valve to do aortic balloon dilatation. In elderly, you may need cardiac catheterization before surgery to see the state of the coronary arteries. So as I said, LVH, left atrial enlargement, LBB and STT changes are the ECG findings. Chest X-ray is usually normal sized heart. We can have the calcification aortic valve. When you have heart failure, you can have pulmonary venous hypertension and post-stenotic dilatation of aorta. So echo can confirm diagnosis, can confirm where the obstruction is, how much is the aortic valve thickening, how much is the valve area, how much is the obstruction in the form of gradient, where is exactly the abnormality, and the effects of aortic stenosis in the form of post-stenotic dilatation, severe LVH. You can also give you assessment of the aortic severity with Doppler and also assess left ventricular function. So the aortic valve disease can be checked by 2D echo, Doppler and 3D, gives you morphology and functional status. So this is the parasternal long axis view showing the different parts of the aortic valve. So the aortic annulus, aortic root, the sinotubular junction, all of it is one component which is involved in the mechanics of the aortic valve. You can quantify the severity of aortic stenosis by seeing the aortic valve area or by measuring the pressure across the aortic valve using the modified Bernoulli equation. In general, if the gradient is more than 50 millimeters of mercury or if the aortic valve is less than 0.8 centimeters square, patient has severe aortic stenosis. So you can classify aortic stenosis depending upon the gradient as well as the valve area into mild, moderate, severe or critical. Like mild is less than 25, moderate is between 25 to 50 millimeter mercury, and severe is more than 50 to 80 millimeters mercury, and critical is more than 80 millimeter mercury. Any valve area less than 0.7 is severe critical aortic stenosis. So what are the options? So to summarize, aortic stenosis is a common treatable disease. Once symptoms occur, mortality rates drastically increase. Echocardiography and cardiac catheterization gives complementary information, and aortic valve dilatation in children and aortic valve replacement in the elderly are effective treatments. A word about aortic balloon valvoplasty is beneficial in congenital aortic stenosis. This compared to the adults, there is significant regression of LVH compared to adults. The gradients can be reduced. Some of the children with aortic stenosis, the gradients can reoccur, especially 20% of cases in the following 10 years. Many of these patients can be palliated again with repeat balloon dilatation. Some patients develop severe, moderate or severe aortic regurgitation, especially if the if valve morphology is bad, like a unicommissural valve, and these patients may require aortic valve replacement when they become older. So this is a 3D picture showing the normal aortic valve, showing the three cusps and the normal opening of the aortic valve. Just to take you through other causes of aortic stenosis or LVOT obstruction can be supravalvular, which can involve the root or ascending aorta, or it can be subvalvular, like a membrane or a HOCM, hypertrophic obstructive cardiomyopathy. So this is a patient with severe LVH. You can see the doming aortic valve and severe aortic stenosis, some amount of left atrial enlargement, and the LVH is characteristically very dominant. This is the post-stenotic dilatation of the aortic valve. You can see this is a picture showing severe aortic stenosis with mild aortic regurgitation. This is a unicommissural valve, which is unicuspid valve, which is one of the poor prognostic factors for balloon dilatation and can produce significant AR after balloon dilatation. And I'm just sharing with few pictures of severe aortic stenosis. This is a quadricuspid valve actually. 4 cusps are there in this patient. Some of the patients with aortic stenosis can have quadricuspid aortic valve. The measurement of the gradients is important because we need to get a parallel beam to get proper measurements of the aortic gradients. So sometimes you can get good Doppler gradients on the apical four-chamber view. Sometimes you may have to go for the right parasternal, high parasternal view to get proper alignment, to get proper assessment of the aortic valve. I think I showed this. This is one of the cases of supravalvular aortic stenosis, which can produce significant disease in the sinotubular junction and produces an hourglass kind of deformity. Sometimes you can have a diaphragm in the supravalvular area producing severe critical aortic stenosis. This is the echo picture showing thickening of the ascending aorta as well as the supravalvular membrane producing, like just like in mitral valve, you can have a diaphragm like thickening in the just above the sinotubular junction producing severe LVOT obstruction. This is diffuse hyperplasia of the ascending aorta. This is subvalvular aortic stenosis. You can see a membrane-like thing just below the aortic valve. Sometimes it can be very thin. Sometimes it can be very thick. Sometimes you can also have some valve tissue which protrude into the LVOT area, producing significant obstruction. So these are the various types of subvalvular aortic stenosis. Really picture. This is one form of subvalvular aortic stenosis. This is the tricuspid aortic valve, and here this is a fleshy portion of the thickened subvalvular aortic stenotic membrane-like structure, which has to be resected to relieve this obstruction. I think. So to summarize, the congenital abnormality of aortic valve can be varied. It can involve any part of the aortic valve, and we had a good understanding of the anatomy and the development to characterize this lesion. And assessment and early detection of aortic valve disease is important in babies and children so that we can give them appropriate treatment. Thank you. Any questions? Does anybody want to ask me anything? Okay, then bye. Take care.
Hello? Hello,
Hello?
sir. Sir, ഒരു ക്വസ്റ്റ്യൻ വന്നിട്ടുണ്ട് LCH കൊല്ലത്ത് ചാറ്റ് ബോക്സിൽ സാർ ചെക്ക് ചെയ്യോ? ആ റൈറ്റ് സൈഡിൽ ചാറ്റ് ബോക്സ് നോക്കിയ സാർ. ആ
ചാറ്റ് ബോക്സ് കാണുന്നില്ല.
Sir, കണ്ടായിരുന്നോ?
ഇല്ല, കണ്ടില്ല.
Sir, നേരത്തെ അബ്ഡോമിനൽ സാർ കണ്ടില്ലേ? അതിന്റെ തൊട്ട് താഴെ.
ഒന്നും കാണുന്നില്ല ആക്ച്വലി. കാണുന്നില്ല.
കണ്ടായിരുന്നേ?
ഇല്ലല്ലോ.
ഒരു മിനിറ്റ്. സാർ, ആ ഷെയർ മൈ മീറ്റിംഗ് വിൻഡോ ഒന്ന് കൊടുക്കാവോ സാറേ? ഷെയറിൽ പോയിട്ട് ഷെയർ മൈ മീറ്റിംഗ് വിൻഡോ. സാർ കേൾക്കുന്നുണ്ടോ? സാറേ ഷെയറിൽ പോയിട്ട്, സാർ ഷെയറിൽ പോയിട്ട് ഷെയർ മൈ മീറ്റിംഗ് വിൻഡോ.
കിട്ടി. Previously we thought the sudden cardiac death is important in aortic stenosis, but now we know that it's not that frequent, and we previously never used to put patients with aortic stenosis for on treadmill, but now we do actually put them to see assess the severity of the functional impairment of aortic stenosis, and that is because we have a lot more confidence now that sudden cardiac death does not happen that frequently as what we believed previously.
സാർ പെട്ടെന്ന് ഹലോ,
Tell me. Is there any more clarifications that you guys need? Then thank you. Bye, guys.
Thank you, sir. Bye. Bye.